Shall we start? Uh, Good evening, my dear friends. I'm Dr. Sood. My qualifications, you can see, I did my medicine. I'm an endocrinologist, diabetologist. Did my critical care from KEM Mumbai. Today we are assembled here to have a broad idea as to what are the secondary infections which surface secondary bacterial infections which come out of critical patients. So I would like to start my presentation with a simple story. First of all, what would you get by attending my webinar? What I want you to get from my webinar is a broad view as to what basic uh, pathologies and what basic infections or secondary infections which come up secondary to the bacterial infections. The scenario what we are right now dealing with is COVID. So today more or less my lecture will be more concerned about the complication or the secondary infections which we normally come across in COVID patients. Of course, we are going to discuss a lot of topics other than that. But let me start with a very simple story. In a Bhagavad Gita, it is mentioned that Lord Krishna, when during the war, at the end of the war, Guru Drona was killed, and his son Ashwathama, he himself being a great warrior, committed three major sins. When he heard that his father has died, he was enraged. In that enragement, what he did was that he crept into the camp of the Pandavas and brutally killed all the sons of Draupadi. That was the first cardinal sin that he committed. According to Hindutva, you can never kill a sleeping enemy. If you do so, you lose all your power and your energy and your pomp and all the good qualities do you have. So after doing that, when the returned, Arjuna returned, he came to know about his son's death. He got enraged and he decided that and he would kill Ashwatthama by evening before the sunset. Ashwatthama, who had already committed the first cardinal crime of killing an enemy while sleeping, had no more powers. So he ran away. He got terrified, and when on the way, he saw that Arjuna was following him. His horses were tired. He got down from the chariot and attacked Arjuna. Now, at that time, he thought, what should I do? The best thing would be to employ the biggest weapon I have. And the biggest weapon we all know at that time was the Brahmastra. So he promptly took out his Brahmastra and he applied it towards Arjuna. Now, this was the second cardinal crime which he committed. Was in a small war, you should not use your biggest weapon. Now the Arjuna had to save his life, so definitely he had to employ again his Brahmastra. But the problem was that when two Brahmastra were fired, it could bring fatality and it could bring the end of the world. So now Sri Krishna, he said, Arjuna, both of you should withdraw your Brahmastra, otherwise the whole humanity might suffer. So Arjuna promptly listened to Sri Krishna and withdrew his Brahmastra. But Ashwasthama did not do it. What he did was that he gave the direction to his Brahmastra towards the womb of the Abhimanyu's wife. Now Krishna, She being a she was being a very, very, very well believer, staunch believer of Sri Krishna, begged him to help protect the son, which Krishna did by Sudarshan Chakra. So now, when Arjuna caught uh, Ashwathama, he didn't want to kill him because he saw that he was ashamed of himself and he did not want to kill him. After all, he was the son of the Guru. So the Guru son demands the same respect, what the respect the Guru has. So he said, let's take her to Draupadi and let her decide what basically has to be done. So he took him to Draupadi, and after Draupadi saw him, said that, okay, you are already have accumulated so many sins. Now I don't want to kill you. So she pardoned him. So what Sri Krishna did was that he said that you have committed a very big crime of trying to kill an unborn child. So what can be done is that we will have to remove all your hair. So once you remove all your hair in a war of your enemy, that means you have destroyed him. So they removed the hair, and Ashwathama had a jewel which always protected him, and so it came out with the hair. So what is the main reason of telling me the story is that there are these three sins committed by him in the holy war of between the Kauravas and the Pandavas. In the same way, we at present are also fighting a war with COVID. As you all know, that more than 6 million people have been infected by corona, and more than uh, 500,000 to 600,000 people have lost their life worldwide. So the topic today is the bacterial infections and what are secondary bacterial infections. And what the message I want to drive through this is that in this war we need not use our best antibacterial tools, because even smaller antibacterial drugs are enough to win the battle. Because if we use all our big weapons, we will not be there. They will not be there when we require them. So with a small story, I would start my lecture for today. Uh, all of all of us know what are infections. Let me start with what is an infection. An infection, as we all know, is an invasion of bodily tissue by a pathogen microorganism that results in tissue injury and which can progress to disease. This is what is infection. Now, next are what are the causes of infection? Causes of infections are different and are varied. They are viruses, viroids, pyrons, bacteria, nematodes, arthropods, fungal infections, and other microorganisms. So I'm not going to go through the whole thing. That's because we don't have so much time. So I just go ahead with these small things: prion, viroids, bacteria, viruses. And now we come to the bacterial infection. What is a bacterial infection? A bacterial infection is proliferation of harmful strain of bacteria inside the body. That, as we all know, that bacteria can infect any part of the body, any area. It can cause different life-threatening disturbances. Bacteria can cause pneumonia, meningitis, food poisoning, and just a few like these. Now, bacterial infections, if we just commonly go to see, are divided into two: gram positive and gram negative. We all doctors know about it. They are Staphylococcus, Lococci, Bacillus, Corynebacteria, Enerbic, and other these all, right? Now, these are the gram positive ones, and there are the gram negative ones, just like the Kauravas and the Pandavas. Now, meningococcal infection in the gram negative, Enterobacter, Mozzarella, Encroid, Salmonella, Pseudomonas. Please pay attention to the Pseudomonas. Pseudomonas is one of the most disruptive of all them in the present scenario. We'll come across the slides and I will explain you what as to how this goes around. Now, brucellosis and other Echinococcus. So the next slide, please. Now, our topic is secondary bacterial infection. So we have defined what is infection, we have defined what is bacterial infection. Now we come to a secondary bacterial infection. The secondary bacterial infection is that occurs during the treatment for a particular infection. It may be caused by the treatment for the first infection or by changes in the immune system. For example, a simple secondary infection is a vaginal yeast which can be taken due to which can occur due to taking of antibiotics. This is an example of what a secondary bacterial infection would be. Now, bacterial co-pathogens, as we all know, are commonly identified in viral respiratory morbidities. As we know, there are many co-pathogenic or bacterial infections, but today, as a topic is concerned about the real-time problems we have, and the biggest real-time problem which we have is COVID. So today, I am going to channelize my energy towards the comorbidities due to secondary infections in bacterial uh, by bacterial pathogens. So the prevalence of bacterial infection in patients infected with COVID is not well understood, as we all know, because COVID is a new disease, not quite well known. There are the facts about COVID. So next slide, I go to yeah, the aim of today's lecture, basically the aim of today's lecture is to determine the prevalence of bacterial co-infection at presentation and secondary infection after presenting the patients with COVID-19. Implications. What are the implications which are there? Bacterial co-infection is relatively infrequent in hospitalization because uh, in case of COVID, as we all know, it's a viral disease, and the most how much effect the bacterial infection has on virus, it is still under a lot of question marks. Normally, what is seen as that viral bacterial co-infection is relatively infrequent in hospitalization. The majority of these patients do not require empirical antibiotic bacterial treatment. Being said so, the role of antibacterial treatment cannot be ruled out, right? And somehow we have got used to an idea of giving the maximum doses, giving the maximum. Why leave something on chances? But this is a which is a very red-like line which we have to walk around. How much to give, when to give, will it cause more harm, will it cause less harm, is it better? Uh, these questions are still not very relatively answered in COVID structure. I go to my next slide. Now I come to the definition. The bacterial infection is defined as acute infection. We all know it can be of two types, basically co-infection, which is present at the time of the disease, and a secondary infection, which is emerging due to the disease, where bacteria were cases where bacteria were detected from a respiratory tract or a blood culture system. Meta-analysis of bacterial infection in patients with COVID-19. Bacteriologic testing methods reported in respiratory cultures in those who were reported with other than respiratory cultures and in other blood cultures are not being discussed in this lecture. So what we would be focusing on is the infection caused by bacterial infection in COVID. The most common one, as we all know, is pneumonia, which is related to lungs. Around out of 3,500 cases, 3,400 approximately were evaluated. And what was basically seen in these infections is that a very large amount of co-infection has been found, somewhere to a range of 14%. Now, the 14% is a very big number if we take into consideration amount of COVID patients which have been found and amount of deaths which have occurred. In the further slides, we will see more things about it. I go to my next slide. These are some of the data which we have seen in 2020. Most of them is from China because that is where the COVID has started or originated, as we can say so. Right now, what are bacterial pathogens? Bacterial pathogens are those which were reported. Were in 14, as I told you, they were reported in around 14% of the cases. This 14% as a very big factor, and out of them, there were particularly two or three types of microorganism species which were found out. One was Mycoplasma, Haemophilus influenza. So these are the two major uh, viruses, bacterial infections which were there. Now the antibiotic prescribing is concerned. Now most of the antibiotic prescribing were broad spectrum antibiotics. As my doctor friends, all of you would know that antibiotic use is of broad spectrum and fluoroquinoquines, quinolones, as well as the third generation spectrosporin, cephalosporin, were required or are being used in today's. As much as 80% of our antibacterial drugs are either broad spectrum fluorochloroquines, third generation spectrosporins, and which are higher at and others. In the next slide, what we I want to say is that when there were hospitalizations for COVID patients, in this hospitalization, the proportion of bacterial infections were quite low. But this is concerned as the lower proportion patients who are not significantly that much ill. The bacterial proportion was quite less. But in critical cases, this bacterial portion is quite high. What I have seen in my practice of treating critically ill corona patients is that uh, though we give a very high dose of a good dose of antibacterial drugs, but the results which we face are not very good. We end up saving the lives of people, but we end up losing them at a particular stage. So what we have to basically avoid is to lose the lives of those precious lives which we have toiled hard to save through COVID. And if we lose them due to some other opportunistic infections, or lose them because we are overdoing certain things, will not be very good thing to do. And secondly, as we all know, there are certain other consequences, which is toxicity, resistance, dyspepsia, and all those factors which are added to it. Previous, if we go to see the previous outbreaks of pandemics, bacterial infections have always increased the mortality and morbidity of those. Earlier on, which was seen were two main organs were seen. Staphylococcus and Streptococcus pneumonia were the most dominant pathogens which were seen in H1N1 and other pandemics which we have seen in the 90s and 20s, late 20s. Now, here I am going to present you the small case of basically comprising of 5 patients. One patient was a female patient who had um, without any underlying diseases, and her tracheal aspirate yielded E. coli. With a good susceptibility antibiotics, the pathogen was then switched on to BT cepacia, which was again from a tracheal aspirate. Now the second patient, and she was given an imipenem use, and obviously uh, that was her course of treatment. The second patient was an elderly male with a lot of multiple comorbidities. He has an IHD, he had the liver cirrhosis, he had a chronic kidney disease, and his culture gave us B-lactive maize, Klebsiella. These were the two major organisms which were isolated from. The third patient underwent liver transplantation for cirrhosis 3 years ago and used tacrolimus as a drug for as an anti-rejection drug. Now, in his aspirate, we got Candida as well as Pseudomonas. And after 10 days, he yielded albicans, and angyrosa as well. Now, in patients 4 and 5, the patient responsible for secondary bacterial infection was Streptomonas and B. cepacia. Now, this is basically a criteria of 5 different patients with different pathogens, different infections. And what do you think? What is the outcome would have been if I don't see the screen right now with me? See, in all 5 patients who received appropriate definitive therapy in 2020, patient 3 died of liver failure. So, if we see the patient 3, why he died, because what was the reason for his so fast deterioration was, firstly, he was on anti-rejection drugs, so the immunity basically was less from the starting, and plus these super infections caused him further deterioration. Now, though his COVID test was negative, what happens, my dear friends, is that we normally, when we treat COVID patients, we have a lot of drugs. We have steroids, we have antivirals, we have low molecular weight heparins, and we have other drugs. A lot of certain times, we end up giving the masala which we have, and we end up saving the life of the patient from corona. But ultimately, he suffers his death not from corona, but from some other infections, such as these bacterial enrichment effect. So that was one of the main reasons for his death, though the main battle was for corona, which he had survived. So this is the importance of treating secondary bacterial infections, because we might end up saving the life of the patient with corona, but we may lose them due to these bacteria. Now, the other is that 1 and 3 had died, as I told you, due to liver failure. 1 and 4 received lung transplant patients. My dear friends, now in COVID, if we say lung transplantation is the treatment, unfortunately, the Indian scenario does not allow us to do that, because in India there's only one center which is doing lung transplant. There have been 6 lung transplants done, and there are around 5 to 6 in waiting. Because of the socio-economic conditions, this is not possible. So then that would be the treatment of choice, the lung transplant. And now what I want to see is that, to show you that the patient number 2 and 5, the patient number 2 and 5, they had received a good therapy, an aggressive therapy. They are still on MV, and they are still not recovering. Their outcome is still poor. We don't know what the outcome would be. Maybe they would have fibrosis. Maybe they might not come out of it. But the time taken is too large. So here also, the role of giving high antibacterial drugs is again under question. Next slide is what are the common antibiotics which we are prescribing to treat staph infections. They are cephalosporin, oxalin, vancomycin. First line antibiotics which we all select, including macrolides, azithromycin, clarithromycin, tetracycline, doxycycline. I might miss a few. The list is large, so kindly excuse me if I do miss few. Other antibiotics are fluorochloroquine, amoxicillin group, macrolide, and antibiotic. Now, which are the tools for investigations? These tools are not, they may not be the full armory of the investigations. Here we are targeting lungs and pneumonia for secondary bacterial infection. So I will retain myself from commenting on everything. So some of them, there are other ultrasound, lung ultrasound and all, which can also be done. So blood tests, chest x-rays, pulse oximetry, sputum, we all know, blood PCR, nasopharyngeal aspiration, blood antigen, tracheal lavages. Now, the next chart shows what are the recommended doses and what treatment. Some of them have MDR risk, mortality risk, which is a high mortality risk. But what common treatment modalities which we have seen is that In aminopenicillin group, amoxicillin, ampicillin, the doses are mentioned at the side of it, ceftriaxone, levofloxacin, and the list goes on. It starts from a plain amoxicillin and goes to vancomycin, linezolid. So this is a small graphic representation as to what they are. Now, some common secondary infection, otitis media, primary pneumonia, myositis, brain syndrome, febrile consumption. These are some of them. I'll go to my next slide. Now, what we have seen in India is that in India, the last pandemic and the last years have showed us that there has been a significant rise in the bacterial infections. All these bacterial infections, which I'm underlining, E. coli, Klebsiella, all all the whole list of them contribute to a major factor of resistance in India. Why? Because they have gone up because we have become resistant of using antibiotics. We have been given a gift of saving life, but that gift somehow has been lost by us by overzealous use of antibiotics. The mantra of treating secondary infections would be to basically use what is required. Do not use weapons which you require for a bigger fight, because what will happen is that in a bigger fight you will not be able to use, you may not have anything. Example, a few super bugs which we are nowadays finding out, we have no answer to them. So here I'll show you some resistance in India. 51% of a very big chunk of them, 53%, 45%. If you see the charts, E. coli cycle, E. coli has risen, Klebsiella has risen, and other infections have risen. These are all because of non-judgmental use of antibiotics, which we are doing. Another problem in India is that everyone wants to see what the other person is doing. If I am getting a result from a better drug, no, but the other person is using a higher drug. So even sometimes, because our patients ask us, why are you using a lower antibiotic? Why don't you give us a higher antibiotic? And somehow our internet has become very important for our patients, because they judge us by internet nowadays, not by our knowledge. Next slide would be, we have seen basically a lot of antibiotics which are being used. Some are lower, some are higher. But what I really think is the requirement of the days would be to break that resistance of an antibiotic therapy, which would be a new antibiotic resistance breaker and a new antibiotic, so that the cycle is broken and we may get the best results for the treatments of the patient. Now, one of those antibiotic resistant breakers are with EDTA, which I have found out is a great help in my typical patients of corona. Those patients of corona who were having respiratory tract infections, who are developing pneumonia, uh, out of 80% of my patients, I have managed them on a basic dose of ceftriaxone along with EDTA. What it does is that it gives something more to play with. At the same time, it retains the basic antibiotic which I want. Yes, in critical ill patients, you might ask me, sir, what would you do in a critical patient scenario? A critical patient scenario, yes, I would switch on to higher antibiotics. Can be vancomycin, can be imipenem, can be meropenem. Another one which I commonly use in a higher antibiotics is a combination of imipenem and netlimycin, which is good provided you have to see what the what the renal parameters are. Sorry. So, but again, I would like to stress 80% of my patients who had a comorbid, basically a score of something around 15 to 18 out of 25, very well responded to a simple sulbactam ceftriaxone combination. Ceftriaxone sulbactam combination. Very well they were managed, and they did quite well, and the result was within 8 to 9 days we were able to discharge him. Yes. On the contrary, as the first case which I described, when I have prescribed imipenem along with natilmycin, my patients have got well, but within 12 days, who were a little badder on the scale. But then they had a lot of other comorbid conditions. Some of them had developed fibrosis, some of them could not come out. They are still fighting with their respiratory problems. And we all know that in COVID, a lot of things are still in dark. We don't know much about it. It's a particularly new disease. We are still learning by the day. I'll go to my next slide. Synergy of, again, ceftriaxone sulbactam in EDTA. There are a few facts about it. Ratio of 2s to 1, and it is found to be beneficial. Here, I would like to just show you a basic chart, whereas if we add antibiotic reflux pumps in major regions of resistance, just by adding a few little bit of EDTA, the concentrations like 128 have increased from smaller dose to quite high, which is quite helpful in treating our patients with for bacterial secondary infections. Again, this is same thing. It is basically a mechanism what EDTA does for it. And here the thing is, the important thing is that susceptibility of E. coli strains were managed very well. This is again a chart basically to show how the E. coli infections have been well covered under this spectrum of activity. The simple drugs again, such as ceftriaxone, sulbactam, which are not very high spectrum but still give us variable results. Some of the Enterobacter, E. coli, Pseudomonas, Klebsiella, all these basic infections which are nowadays causing a havoc with us, with our patients, be it COVID, non-COVID, especially in diabetic wounds. This is a good drug which I have found which may prove beneficial in the future for us. The results is, what I have seen is that this AE therapy plus colistin therapy, in my personal experience, have significant higher efficacy as compared to meropenem and colistin. Meropenem and colistin, as far as I have seen, along with A therapy and colistin therapy, what I have seen is that uh, imipenem and natriamycin is a very good combination. If your renal parameters are fine, I would suggest you, if critical in patients, you can definitely go ahead with that. And next is some side effects which we normally will have, which we all need to know, are diarrhea, dyspepsia, nausea, vomiting, phlebitis, pain, headache, dizziness. So these are some of the things. Now, about all, after discussing all these things and coming to one simple conclusion, if we come around, is that among all the patients, I'm talking about particularly about COVID because it is the current scenario. So antibiotics role is, my dear friends, not very big. We don't need to go on to brahmastras to take care of an infection. In case if we use all our big weapons in a war with COVID or in general, we might go to a stage where we might just not have anything. All the virologists, all over the world are very much concerned about these superbugs and how these superbugs come. It is our mistakes. In the present Indian scenario, what I have observed is that those drugs which we have used, drugs like azithromycin, drugs like amoxiclav, they have been used so much that now we don't find that result in it. So what we should do is that we should, what is my recommendation is that we should start with a smaller drug and give it a chance to help us with the infection rather than switching uh, to a higher drug. Yeah, I am an intensivist and I am an aggressive intensivist as well. One of my teachers told me one very simple thing, that you don't let an infection grow so much that you have to aggressively treat. So if you start with a simple antibiotic or a simple antiviral or simple whatever is required, you will get the desired results. But then, yeah, I again add to it that if you have critical patients, you should definitely take invasive action and go to a higher support. So, but the conclusion for today's talk would be that the patients of COVID-19, the bacterial co-infection is low right now, by God's grace. The usage of antibiotics was high. Even for smaller things, we were going to imipenem, tazobactam, penicillin, and all the higher vancomycin and all those things, when we can very well do it with a simple ceftriaxone, sulbactam combination. And we know even the WHO guidelines state that we don't need to go so high for that. Use of imperial hospitalized, particularly those without critical illness, as I told you. Next slide would be a big thank you. What would I add to this? What would be my take back from my initial story of the Mahabharata, which I told you, was that we do not need to use all the Brahmastras in our hand. We have to be very judiciously using those things which we have, especially antibacterials which we have with us. So a simple antibiotic is enough. A normal antibiotic is enough to take care of the patients. Yes, we need when we need to go higher, we do. I'm quite sure about it. One thing more, as we are discussing COVID, is that the role of immunomodulators in it. Immunomodulators are a very potent drug in controlling these bacterial infections, reducing the bacterial infection as well, because the T site death, the T site death is controlled by them, which plays a really very important role in reducing the hospital stay of the patient. And as you know, the lower the hospital stay of the patient will be, the less will be the acquired co-infections. So I hope this is small session of ours was interactive. It was kind of interesting to you. This topic is very large and very big. That is why I choose to take just a small part of it for our talk, and we have less time in our hands as well. So maybe next topic we might take for something bigger one. So thanks a lot. I hope you enjoyed the talk. Any questions would be welcome. Okay, dear friends, thanks a lot. Be safe. Okay, close it.